All right, so as folks trickle in, I'd like to welcome everyone to today's CHEER webinar on parents and neonatal research. As we begin, I would like to start with a land acknowledgement, and I invite all attendees to put in the chat where they are joining us from. So the CHEER project is housed at Queen's University, which is situated on traditional Anishinaabe and Haudenosaunee territory. To acknowledge this traditional territory is to recognize its longer history, one predating the establishment of the earliest European colonies. It is also to acknowledge this territory's significance for the Indigenous peoples who lived and continue to live upon it, people whose practices and spiritualities were tied to the land and continue to develop in relationship to the territory and its other inhabitants today. The Kingston Indigenous community continues to reflect the area's Anishinaabeg and Haudenosaunee roots. There is also a significant Métis community, and there are First Peoples from other nations across Turtle Island present here today. I would also like to thank the video conference services at the Smith School of Business for providing the platform and technology, and Jason Miller for supporting this event today. Just as a reminder that this webinar is being recorded and will be available later on the CHEER website. For those who may not know about the CHEER project or would like to learn more, the CHEER project is the Canadian Collaboration for Child Health, Efficiency and Excellence in the Ethics Review of Research. It is a Canada-wide initiative on a mission to improve child health by streamlining research ethics review for child health research. CHEER is led by Clinical Trials Ontario and MyCERN in partnership with Queen's University Faculty of Health Sciences, Office for Professional Development and Educational Scholarship, and investigators and collaborators across the country. CHEER is a CIHR grant-funded project, and as part of this project, we have an education component aiming to provide educational opportunities for researchers, administrators, REBs, patients, and families to support high-quality and efficient REB review. You can find more about us online at cheerchildhealth.ca. And now it is my great pleasure to introduce today's speakers. Joining us is Dr. George Schmolzer, Betsy Pilon, and Rebecca Pierce. Dr. George Schmolzer is a clinician scientist with a focus on neonatal, infant, and pediatric resuscitation research and large clinical trials. He is the director of CSAR, the Center for the Studies of Asphyxia and Resuscitation at the University of Alberta, and a neonatologist with the Northern Albertan Neonatal Program, providing care to critically ill newborns. Dr. Schmolzer obtained his MD at the Medical University Graz in Austria and trained in pediatrics and neonatology at the Medical University Graz and the Royal Women's Hospital in Melbourne, Australia. He obtained his PhD at Monash University, also in Melbourne, before completing a Banting postdoctoral fellowship at the University of Alberta. He is currently a professor of pediatrics and an adjunct professor of pharmacology at the University of Alberta. He received the King Charles III Coronation Medal for his work on lung health for preterm infants. Dr. Schmolzer's research focuses on understanding physiological changes during fetal to neonatal transition to improve outcomes for newborns, improve approaches to neonatal, infant, and pediatric resuscitation, and examine how physiological changes can be used to improve short and long-term outcomes of newborns, infants, and children. Betsy Pilon is the executive director of Hope for HIE, the premier global nonprofit patient advocacy group dedicated to improving the quality of life for children and families impacted by neonatal and pediatric acquired hypoxic ischemic encephalopathy through awareness, education, and support. Hope for HIE connects over 10,000 families, researchers, clinicians, and the greater community worldwide through a comprehensive network. After her own son, Max, was born in 2012 with HIE, it was difficult to find educational resources or connections with other families. Eventually, she found a small group of families gathering on social media. Working with the existing group, she led the efforts to start the Grassroots Nonprofit Foundation in 2013 and has been relentlessly growing out the organization in awareness, advocacy, education, research, and support since that time with many other families. She is based out of Detroit, Michigan, and is an accomplished speaker, writer, advocate, and connector with a background in marketing and corporate communication in healthcare, education, and automotive. She serves on the board of directors for the Newborn Brain Society, co-chairing the Communication and Networking Committee, as well as many neonatal and neurology-related work groups, task forces, and committees, elevating the lived experiences of the HIE community through patient advocacy. And finally, Rebecca Pierce is a high school vice principal who lives in Montreal. She is the mother of a surviving twin who was born at 25 weeks and 5 days gestational age in 2009. Over the years, Rebecca has been a co-author on a number of papers discussing parental views of prematurity and has become an advocate for trying to improve outcomes of prematurity by including parent voices and perspectives in research. She is also the chair of the Canadian Premature Babies Foundation Family Advisory Committee. And now, without further ado, I'll hand the reins over to Dr. George Schmolzer.
Thank you, Megan, and welcome everyone. It's a great pleasure to be here today to discuss, how can we approach consent, and particularly hear the parents' voices, and to help us to better understand how we can do research better moving forward. I think what we have planned is 3 presentations where we just kickstart the different topics, and then we really hope for a lively discussion about this topic. So I will start sharing my screen and present you about modes of consent, and this is really my main part for today's talk. I would just like to disclose a few things. That I received grant funding for many of my studies from many government entities. I do a lot of volunteer work for Heart and Stroke Foundation, American Heart Association, and the International Liaison Committee on Resuscitation. And I've designed some resuscitation games. Apologies. I thought, talking about consent, I focus to a certain degree on resuscitation, because this is often an area where it is more challenging to obtain consent compared to potentially doing a study on the NICU, where you have time, sometimes days, maybe weeks, if it's later in the course of a baby being on the neonatal intensive care unit, to talk to parents and potentially obtain consent. Now, if you look at the resuscitation guidelines, given that it's often quite challenging to do research around birth, it's to no surprise that despite best efforts from everyone, that most of our evidence remains rather low or very low. And that's certainly a concern not only for the clinicians, but certainly also for parents and anybody else involved, because we try to get the highest evidence possible, but certainly in this area, it's often challenging. Now, looking at neonatal resuscitation research, there's many barriers we face when we try to do that, and there's a list here of all the barriers I was thinking of or found in publications, and certainly today we're really focusing on obtaining consent. That's the main thing I'm talking about. Now, trying to obtain consent, there's many different approaches we could actually use, and I think most of them are known to the audience, but certainly the one we most commonly use for studies, and that's for everyone up to adults, is the prospective informed consent. Using deferred consent or consent waiver, and this is basically the same, but it always depends what jurisdiction you're in. They use different terminology for that. It's something which is commonly used in the delivery room, but maybe not known to everyone. And there are other forms which are used, but maybe not as often, or often maybe also in a combination, like short oral consent, an opt-in or opt-out consent, or a waiver of consent. Now, as I said, the prospective informed consent is most often used. It's often used antenatally, but also postnatally if you do studies later in the course. And we generally give a full explanation of the study before participation. There's enough time to be asked questions, and then the parents can decide without pressure if they would like to join that study or not. It's commonly used in non-emergency situations, or also often called planned research. It's not really practical during emergencies because the time is quite limited, and the parents are often distressed, so it's hard to use that at that time. And during that time, more commonly used is a consent waiver or deferred consent approach, where the study proceeds without prior consent due to the urgent medical need. And parents are then often informed as soon as possible after the intervention that a study has occurred. What it helps is that we can include critical ill infants who would be otherwise missed. As with all other consent approaches and with every other study as well, it requires ethical approval, and there is strict safety monitoring as well as strict guidelines when you can actually use this approach. Now, if you look at difference in these two approaches from a consent rate, you can see that if you use waiver, that's from an American study, so that would be the deferred consent, you get a much higher recruitment rate compared to using antenatal consent, which often is quite limited. It often misses high-risk cases or cases where there is established labor already. Often there are more healthier subjects enrolled. It then can lead to biased outcomes. So there is this idea that if I use waived consent or deferred consent, it can improve equity because I get a wider range of patient involved, because I can also get the sicker babies who I might miss otherwise involved, and can then apply the outcomes better to the real world, instead of having a healthy limited number of patients which might not represent the whole spectrum of your patients. Other approaches which are available but maybe haven't been used in the past as commonly or often or used but not under this umbrella is an opt-in or opt-out consent, where either parents must actively agree to opt in, and these are then often also considered that they are the gold standard to respect your autonomy. But again, it can result in lower recruitment and bias because they have actively agreed to opt in, and again, may not reflect the real life patient population. The alternative is opt-out consent, where everybody is automatically included unless you decline. And that's often used or can be used for large or routine clinical studies. There's an approach that the parents can say no before it happens because there's flyers around, but often it's again then used as a deferred consent approach where you might go back to the parents afterwards and ask for their permission to continue to collect data. And it still requires a lot of transparency, ethical oversight, and certain rules when you can use that. In one of the trials we're doing at the moment, which is called the HILO trial, where we randomize hospitals to either start at 30 or 60% oxygen, we use kind of that approach. We still use deferred consent to then get to continue to collect data and do long-term follow-up. But in the end, the hospital is randomized and is changing their hospital policy. So you get all involved, and then there is a way for the parents to say no, and they can opt out, and you can see the decline rate is relatively low, so a small number of parents opt out. Other approaches is that you add a short oral consent, which is basically when you're in the delivery room, hypothetically, and you start doing a study, you give a brief verbal explanation of 1 minute or so or less, so that everybody of the family hears it and understands that there is a study is ongoing, and then you obtain full consent written later when the parent is ready. There's only one study I'm aware of who has used that so far, but they had good success. That was in the UK a few years ago. But that's certainly something which is maybe something in the future which will be more present, that we try to do this. And then there is a complete waiver of consent, where there is never consent obtained. It occurs, but it's not something which is routinely used anywhere in our daily routine or in our research practice. But it happens, and I will have a few examples of that as well. I'm really focusing on the consent waiver and deferred consent a little bit more in my talk now, because this is something which is an approach approved by the Tri-Council in Canada, and it is also often used by clinical trials, particularly in the delivery room or in early stages of the first days of after birth, with really tight, strict guidelines when you can use it, and certainly ethics approval. And I just wanted to highlight a few studies where different consent approaches have been used in the past. I think in a classical example where they used a waiver of consent was this study where we had this long-standing routine when the head was delivered of a newborn baby, and there was meconium, then we had to suction the mouth and the nose. Wasn't based on any evidence, but people in the US as well as in Argentina thought, okay, let's study that, and they really just then randomized to suction versus no suctioning when the head was born, and basically found in the end that it doesn't really make a difference. It does not help with reducing meconium aspiration syndrome. That was one of the things they were interesting in. So they used a waiver of consent, and I mean, having done this suctioning many times, I'm glad to see this study. Was it right to use a waiver of consent? This is something we can certainly discuss in a discussion later. But again, meconium is something we don't know when it's happening. So getting antenatal consent might have been quite challenging because you never know when meconium occurs in during delivery. Another study who's using a waiver of consent is this called aeroplane trial. And this is a study out of Australia where they actually randomize hospitals again to either 21 or 30% oxygen in babies who are born 32 to 35 weeks gestation. It's unblinded, it's cluster randomized again, and is using a waiver of consent. Now, this caused a little bit of controversy in Australia because a journalist heard about the study and started to write about it, that it raises ethical questions because we're doing a trial on baby without the parents' consent. It didn't get viral. It was just, as you can see, 8 comments overall. And those comments weren't too negative, but certainly something where the team has learned a lot, and given from discussions with them, will approach things like this differently in the future. Sometimes when we try to do things and try to recruit as many babies as possible, it is quite challenging to always try to do antenatal consent and often then opt for deferred consent. And I wanted to highlight a couple of studies where this was done, but it certainly was harming more than doing good. So then it always raises the question if this approach was the best. And this is one of these examples where we try to find out if we maybe can do milking the cord, where we just milk the cord, like you strip the cord, compared to just doing the leg cord clamping. Early studies showed, hey, it works. It's not more severe than, it's not worse, has worse outcome or any adverse events compared to cord milking. And if you look at then the larger study, which was followed, it had to be stopped because there was overall more infants getting a severe intraventricular hemorrhage, grade 3 or 4, when they were milking, compared to doing umbilical cord, delaying the umbilical cord clamping. And that could be based on an animal study, which wasn't available when they started the study, but came available during the study and showed, hey, the reason why this maybe is not good is because of the fluctuation in the blood flow to the brain. So this study was certainly stopped. And again, it used deferred consent as well as prospective informed consent. So certainly something when we do studies, we need to be aware of that yes, it might not be optimal to use that all the time, but you can see that with this approach, there is a lot of babies enrolled with waiver of consent and a small number with antenatal consent. Certainly something which is good for the study, but as you can see, it was not optimal because it was harming preterm babies. Another of this example is if you want to use a sustained inflation at birth, and this is something we don't do anymore, but if you go a decade back, it was certainly something which worked well, that because sustained inflation rates the lung really nicely. And this is what we want, that we want to get the air and the oxygen in as quick as possible. If you look at early studies, they all of them, some of them showed it's good, some showed it doesn't work well. So there wasn't really much information out. Some of the small trials showed, hey, it's not bad, it doesn't cause any harm, potentially has some benefits, so larger study is needed. Again, a large trial was done and found the opposite. Again, hey, it wasn't as good because the mortality was higher with the sustained inflation compared to just doing our standard resuscitation. And again, 2 consent models were used, deferred consent, because there was this feeling that this is a good idea, and as well prospective informed consent. And again, something which can be discussed because, again, the study was stopped early because it caused more harm, and deferred consent might have been not the optimal approach, again, in this approach. I already mentioned the HILO trial, and I just wanted to mention it one more time, just to highlight how different it is across the country, even in Canada, to do studies. Again, in the HILO trial, we have this 30 versus 60% oxygen, where we randomize the hospital, and many sites, when the study was approved across Canada, got deferred consent from the ethics committee. However, there are some hospitals who got a waiver of consent, so they don't even need to ask the parents. So even within Canada, with one study where one ethics committee says, hey, this is a good idea for a deferred consent because it's at birth and we don't know how much oxygen we need. Some ethics committees across the country have said, no, you don't even need to ask for permission, you just do the study. So this is just also highlights how different it is across Canada, that you get different opinions from different ethics committee. And this is one of the great things, hopefully CHEER will in the future help us to move forward, to get a more uniform consent approach as well. That's all I wanted to share today, and I'm looking forward to the next talks and the discussion afterwards. Thank you so much.
Thank you so much, George. And I'd just like to remind everyone that we will have time for discussion at the end. So if you have questions that come up for you during any of our presentations, please do type them in the Q&A. The button is available on the taskbar on the bottom of your screen. So next, I would like to hand it over to Betsy Pilon. Betsy?
All right. Well, I'm thrilled to be here, and thank you so much for including me. And I'm elevating today the experiences of a community of full-term families, primarily in the NICU setting. So these families have a wide variety of causes that leads to a NICU stay. Something doesn't go right either during gestation or in and around birth. And the unique thing about the HIE community, hypoxic ischemic encephalopathy, is that these families enter the community and have one current therapeutic, and I think the history of therapeutic hypothermia, which is currently the only safe and effective approved therapy, is unique and worth talking about today, because it is something where families had to consent in a very short time frame for something that sounds like science fiction. So I want to talk a little bit today about a support model and involving patient families in neonatal research, and kind of the history of that in our community. So this is my why of why I'm here. Almost 13 years ago, it'll be April 23rd next week, was when I first learned about HIE. My son Max was born in April 2012. He was my first pregnancy. Everything was normal until it wasn't at 37 weeks when he stopped moving. I had worked for the health system that I delivered into, went in to get checked out, and found that Max was in severe distress. He was delivered by emergency C-section. And I want to pause and just talk through the consent process that we had. So this was not a clinical trial that we were involved in, but in 2012, essentially taking the baby's temperature or down to a specific temperature to slow down the secondary injury that happens with HIE. Was at a time when it was not fully accepted as standard of care, but it was in the process of becoming so. So when we were approached to consent into transferring him and starting therapeutic hypothermia, it was within 20 minutes, after we had gotten out of recovery, probably within the hour of Max being born, at 1 a.m. So this was a time where we had the neonatologist who is in the delivery room, had checked him out, came out to us and said, he qualifies for this newer therapy, but we can't offer it to him here at this hospital. He needs the higher level of care. And so we'd like to transfer him to downtown Detroit to receive therapeutic hypothermia. It has to be initiated within 6 hours of birth for it to be have a chance at being effective. And so for us, it was an easy yes to consent him in to receive the therapy. We, had full trust that the team knew what they were going, what my son needed and what they were going to do. We had never heard of, full-term babies needing this, or that, there would be anything other than maybe a transient couple of days that he would need care in the NICU, because there was such a lack of representation of anything outside of, premature birth within the NICU representation. And so the typical experience of an HIE family is something doesn't go well in and around birth, whether it's something, again, in gestation or during the birthing process, getting to the NICU, getting a baby into cooling. And then typically on day 5, babies are given an MRI, and you're kind of just waiting and hanging out, as a parent, kind of panicking of what the MRI could show, because HIE is under a bucket of neonatal encephalopathy, and there are many different causes of that. So it's also used as kind of a rule out or a confirmation to learn more about what we may face with our babies. And then after the MRI is done, typically is when you can first hold your baby, although there are a lot of people looking at how holding during cooling can be facilitated earlier for families, which has been shown to decrease cortisol levels of mom and baby and improve bonding. Like anyone else in the context of giving birth and having their baby. Go through the NICU duration, discharge, and then looking at NICU support. So for us, Max's MRI showed moderate damage to a few parts of his brain, and we were given actually, I think, a really good communication course with his neonatologist and neurologist of that wait and see, and leaving room for hope within our journey moving forward. At that time, there was no mention of HIE or a diagnosis. They just said something happened to the brain. And one day we had family center rounds until one day when we didn't. And I overheard the term encephalopathy. I went, texting people I knew, including my sister-in-law, who's a pediatric physical therapist, wondering what that meant and could mean for our child. And then at that time, we left the NICU without any connection to any support, and feeling isolated and frustrated, thinking that there must be other families that have gone through this. Cooling itself sounds like it's science fiction. And so I always wondered how families got to that point and how that therapy got to that point to get families to consent into something that is hands off of your baby, taking them down to low temperature, and being told that you can't hold, feed, cause a ruckus to bond with your baby as well. And so, next slide, come on. Apparently over here in the US, we're a little cranky and slow today. And so today, whoops. So I found the Hope for HIE community shortly after we got out of the NICU from Googling in the middle of the night and being connected to other families. Today, this is our community over, we're now over 10,000 families connected. We have several hundred across Canada, and around the world. Families that come together and support one another, and many that participate in patient-centered research in Canada and beyond as well. So at the time Max was born back in 2012, when we got out of the NICU, the front page of the Detroit Free Press had the Shankaran et al. Study results from long-term outcomes, which I thought was really interesting. And this was heralded as a landmark study, and so it was very interesting to have Dr. Shankaran based out of Detroit, which sometimes does not feel like a epicenter of research and things like that. And so it was pretty special to see that, but just to look at the context of where we've been now over the past 13 years in the context of research. And so when I started connecting with families and hearing about cooling, people talking about at that time, my baby was cooled, my baby wasn't cooled. There were families that were connecting who had children that were teenagers and children who were very young, like mine. And really now what we have is 20 plus years of family participation across all major HIE trials. And lots of really amazing information about what matters most to families and what their experience was. Those that not just consented into these trials and having to do so again in a very quick time frame. Many times families are separated because the baby has to be transferred down or transferred somewhere into a higher level hospital. And mother and baby are often very separated very quickly, and how the consent process. So there's a lot stacked against the deck for families to be consented into this. Now it's considered standard of care for moderate to severe HIE. But I think back to those families again early on who were separated in other HIE trials that have happened, including the HEAL study with EPO that was studied. We have about half the cohort of those families in our community, and it's been really interesting along the way to get their experience of people that, again, opted in, opted out, or opted out after the NICU, and looking at what the diversity of those experiences were, how families in more systemically marginalized communities experience healthcare, and the impact to trusting. That sounds crazy. Maybe promising, but definitely a lot of factors that go into how a family could be consented in and what that key messaging is. So my background is in marketing and communications. I started in automotive because I am in the Detroit area and moved to healthcare. And so a lot of the work that I've done in my past is relating to, high stakes communication strategy, a lot of very complex communication planning. In particular, I had an opportunity to work with a lot of a large merger and acquisition work between some large health systems, and lots of different timing and sensitivities around those. And that work really has stayed with me as I've been in this role, in particular working for HIE and growing advocacy, really elevating the needs and the voices of the families who have gone through this. There are thousands of families who understand this experience of the acute high stakes consenting and treatment, and what do they have to say that can help researchers have better consent rates and better and leading to better care and better co-production. And I know Rebecca's going to talk, and I'm such a huge fan of the work that she and Dr. Janvier have done in looking at the preemie population of what matters most to families. So I'm going to tee that up a little bit. But looking at how can we for our community and others in neonatology come together and improve research and make sure that it's relevant to families, that we're addressing things in the most helpful ways. So we know that the landscape has changed over the past couple decades. Initially, it was physician and researcher led. Then we are moving to families and patients as partners. And we also have patient family led research now, where patient advocacy organizations and groups are actually funding research and setting patient-centered research agendas to shift from that reactionary research to what really matters most to the communities that are being studied. So I wanted to share this as well as we think about how we can co-produce and how we've done it in a model that I mentioned, the Halo of Support model, where it looks at from the beginning, meeting together and looking at trial design and planning and implementing a strategic communication planning process right in the beginning. To think about at the beginning of how we're going to communicate with families, not just in consenting, but how these messaging, how we can optimize messaging for, the diverse families that we want to enroll. And what that, leads to is having stakeholder engagement where you are an equitable partner, not a check mark, that you have a structure, a cadence, and expectations of the team co-producing this work. And you're looking at how you're communicating and engaging families across the spectrum of what the scheduled activities look like for each study. Because without doing that, that's when we see this attrition can be a real issue. And if we don't have good data at the end, then we're not going to know if the intervention is effective or not. And so I think, a lot of the barriers that have happened in neonatal clinical trials really are communication issues, and how we can take a systematized approach and some pedagogy from other areas of, different communication tactics and strategy plans and look at them ahead of time. There's been a lot of discussion recently of a study that, came out and it published in a very prestigious medical journal, but the families had not been communicated with yet about what those results were. And that's an opportunity where, again, if you go back to the beginning of the process and think about how are you going to disseminate the results and what does that look like? What are the granular details? What is the timing? If something is going to be published at 12 p.m., when are you going to let the families know? Is it 12:01 or is it 11 a.m.? And what is acceptable to everyone that wants to ensure that this communication goes well? And what is that communication? And how do you work with families to make sure that it is respectful communication and something that is valuable to the families that have spent a lot of time being a part of these trials? So just to share a little bit about how we've partnered with different people. We're partnering on different academic and commercial trials. But, as an organization, how we've grown is making sure that we have dedicated support services for families in and out of the NICU with a social worker, child life specialist, whole family services, and then bereavement and loss, which unfortunately happens across all neonatal diagnoses, it feels like. And then what we can provide for those research partners is, again, the best practices for patient-centered trials, how to engage families longitudinally, how you can disseminate information, consult along the way, and have a mechanism for feedback. And I think a lot of times what we've found is families will give us feedback that they're not so sure that will be received well to the medical team or to the NICU that they were in. And really a lot of that feedback comes in a peer-to-peer venue. And how can we elevate that in a respectful way to let people know how we can make this a little more successful. So, families can opt into that support. And families that don't opt in also get support. So it's an equitable support system. And looking at what that NICU journey is through discharge, and how you can, multi-center studies have a lot of opportunity for variation and how things are done site to site, and how can you build some consistency across the many partners that are involved in these studies so that families have that more consistent experience for them. And then along the way with these partnerships, when these things do come up and there are problems to solve, you have a chain of how you can work through those in real time. And that can happen with consenting as well. We're a partner in a couple of different trials now, and we meet regularly on how consenting is going and problem solving what they're hearing and working with the patient and family stakeholders in real time on how we can help. So I just want to thank you all for having me. I'm excited to take questions and talk more later and turn it over.
Thanks so much, Betsy. And now we are very happy to turn it over to Rebecca Pierce. Rebecca?
All right. Can everybody hear me? And can everybody see
Yes.
this? Okay,
Perfect.
perfect. So I had two potential talks today. One was involving parental perspectives about emergency consent and consent forms. And I'm glad that I chose this talk because a lot of what I was going to discuss was covered by the two amazing other speakers. So I'm going to be talking today about including parent voices in prematurity outcome research. And thanks to Betsy for giving a little bit of advanced notice about what I'm going to discuss today. So my two objectives for today are to talk about neurodevelopmental impairment, or NDI, and the follow-up of extremely preterm babies, and then also to present the Parents' Voice Project and its findings. So in Canada and around the world, children who were born extremely preterm undergo a standardized follow-up, usually between 18 to 24 months of age. And the purpose of this follow-up is for data collection, but it's also to monitor children for growth and development, and also to refer them to early intervention if necessary. So the focus of this follow-up is really on neurodevelopmental impairment, which from now on I will refer to as NDI because neurodevelopmental impairment is a big mouthful. And so specifically when we're looking at NDI, we're looking at cerebral palsy, developmental delay, hearing, and visual impairments. So in Canada, children are either categorized as having no NDI during this 18 to 24 month follow-up visit, having mild to moderate NDI, meaning they're a level 1 to 2 on the gross motor function classification system, and or one standard deviation below the mean on the Bayley Scales of Infant Development, which is a test that measures cognitive, motor, and language delay. Or children are classified as having a severe NDI, meaning that they're a level 3 to 5 on the gross motor function classification system, 2 standard deviations below the mean on the Bayley, have profound hearing loss, and or bilateral blindness. So I'm just going to hide this down here. Okay, so the important thing is to note that in different neonatal follow-up networks, there are actually different definitions of severe NDI. So that means that the statistics of children, about the number of children with severe NDI really varies depending on which definition is used and its stringency. So for example, one study found that depending on which definition is used, the incidence of severe NDI in infants that are born between 23 and 28 weeks gestational age varied from 3.5% to almost 15%, again, depending on the definition used by the neonatal network. So this is a big problem because NDI is actually used to counsel parents of extremely preterm babies about important decisions for their children, like resuscitation or the continuation of life-saving measures. So the question that we could ask ourselves is whether NDI should be the only outcome measure that's the focus of clinical and research activities. And this is where the Parents' Voice Project and my implication come in. So my daughters, Marin and Lily, were born unexpectedly at 25 weeks and 5 days gestational age in September of 2009. And 1 week later, Lily developed a sudden infection that led to a perforated intestine and a brain bleed, and she died that day. And all the pictures you're going to see here from now on are of my daughter, Marin. So she spent 4 months and 1 week at St. Justine Hospital in Montreal, and much of her course in the hospital was really difficult. So she had the same bacterial infection as Lily. She required a type of heart surgery that's very common in preterm babies. It was really risky because she was unstable. She caught a rare fungal infection, developed bronchopulmonary dysplasia, or BPD, also known as chronic lung disease of prematurity, and she spent lots of time on 100% oxygen or on a high-frequency ventilator. Marin was on a ventilator for a total of 7 weeks, and she came home on oxygen for 6 weeks. And finally, a few weeks before we thought she might finally be discharged from the hospital, she had a routine MRI, and we discovered that there was moderate damage to her cerebellum that had been caused by a brain bleed. So we certainly had no idea what this meant for Marin's future or for her. So we tried to find information or research to help us understand how Marin's prematurity would impact her, which I now know are called outcomes, and how this might also impact us as a family. And the research that I read in 2009 was not particularly reassuring. So all the literature was very deficit based, and the focus of the research into outcomes of extreme prematurity then, and really for the most part still now, is on NDI or neurocognitive outcomes. So for example, blindness, deafness, cerebral palsy, the Bailey test and its components, IQ below certain cutoff, but also things like learning disabilities and developmental disorders like autism. In many or most of these studies, children are either categorized as having the condition or not, but we all know that there's a huge range of functionality and impact for things like cerebral palsy, cognitive or learning difficulties, and autism. Many studies did and also still do include composite outcomes that were a three-letter word or diagnosis or deaf. So for example, the outcome of many studies is BPD, bronchopulmonary dysplasia, or deaf, ROP, retinopathy of prematurity, or deaf, NDI, neurodevelopmental impairment, or deaf. And this was, and quite frankly, is still strange to me as a parent, because these two outcomes are clearly not at all similar to families. So Marin's diagnosis of BPD was not at all the same as if she had died. So this really leads to the question that I discussed previously. Why has NDI become so central to the ways that families are counseled and how prognoses are discussed with them? And how does the focus of NDI really address the concerns of needs of parents of babies that are born preterm? And this is why including parental perspective is so important. While research views prematurity as being only a deficit, the ways in which parents describe their children and put their problems or their outcomes in perspective is often very, very different than the views of healthcare professionals. Regarding what is and what is not being measured, most of the outcome measures that have been chosen for research have been done so by doctors and scientists without considering what parents or families may consider important and concerns that they may have. In their 2020 paper, Outcomes from the Other Side, neonatologist Nir Marlowe and his colleagues point out that whereas we take care to develop outcome measures that researchers and clinicians consider important, it's common for parents and now individuals who were born very preterm to report back to us that to their minds, these are not the major issues. So in 2018, I was invited by Annie Janvier to be part of the Canadian Parents' Voice Project, which is a series of different studies that engaged parents in redefining important outcomes following preterm birth. And these studies have gone a long way towards including parent voice and suggesting which outcome measures are missing. So this is a picture of all of the members of the Parents' Voice team, consisting of doctors, sociologists, and also parents from Toronto, Vancouver, and Montreal. The next two slides are a list of the publications from the Parents' Voice Project, if you would like to read more about the research. So one of the questions that was explored in this project was whether parents agree with the medical classifications of neurodevelopmental impairment. And the answer to this is no. Parents tend to be more positive about their children, and we have data to support this. So this study of the Parents' Voice Project aimed to compare parental views of NDI with the medical definition that's used by the Canadian Neonatal Follow-Up Network, or CN-FUN. So during this study, parents were asked whether they felt their child was developing normally or had a mild, moderate, or severe developmental impairment. Parent responses were compared to their child's CN-FUN developmental assessment that used current NDI definitions using Cohen's kappa statistic. So the first important result in the top left-hand corner is that the agreement between parents and CN-FUN response is low with the Cohen's kappa of 0.29. So if we look overall, 54% of children were considered to have no NDI by CN-FUN, whereas 68% of parents classified their child as having no NDI. When the child was classified as normal by CN-FUN, 83% of parents agreed. When a child was classified as having a mild to moderate NDI by CN-FUN, 40% of parents agreed. And when a child was classified as having a severe NDI by CN-FUN, only 12% of parents agreed with this. So when we look at the agreement of parental classification, parents view their children as being less impaired than scientists or doctors do. A second question that parents were asked was, do parents agree, or that we asked, was do parents agree that conditions that doctors call severe disability are actually severe? And the answer to this question is also no. Parents tend to be more positive. So this project used vignettes to see how parents perceived the severity of disability, but without using medical terminology or medical diagnoses. So these vignettes were developed based on classic definitions of severe NDI. The survey was distributed to the parents of very preterm children nationally and internationally using the snowball sampling technique. So here's an example of one of the vignettes that describes a child that has a language delay, but without any visual, hearing, or motor problems, but without, again, actually using these terms or including any medical diagnoses. Some of the vignettes also included composite outcomes. After each of the vignettes or scenarios, parents were asked 2 questions. If 0 is the worst possible health and 10 is the best possible health, where do you think this child fits on a scale of 0 to 10? And does this child's case describe a severe health condition, yes or no? So here are the results for both questions. So the vignette or the situation that was rated by the fewest parents as representing a severe health condition involved a child with cognitive delay based on the results of the 18-month Bailey test. The single outcome that parents rated as the most severe is a visual impairment, with almost 51% of parents rating this as a severe health condition. The overall vignette that was rated by most parents as representing a severe health condition involves cerebral palsy and a language delay. And it's interesting to note that 55% of parents, I say only because I don't think it's that many, rated this as a severe health condition and also saw the health of a child with this composite outcome as a 6 out of 10. So the part of the Parents' Voice project that was carried out at St. Justine involved exploring the perspective of parents about the health of their premature baby, the impact that prematurity had on their lives, any informational needs that they might have had, and also any decisional regrets parents had. So parental perspective was measured using an open-ended questionnaire given in multiple formats, and the results were analyzed thematically by a multidisciplinary team. So here are some of the comments, I won't read all of these, that were collected during the study. And you can see that many of the answers that parents gave us were quite long and detailed. When we thematically analyzed parent responses, 74% of parents reported both positive and negative impacts of prematurity. The positive impacts included gratitude, perspective, a change in perspective, stronger family connections, and seeing their child as a gift or miracle. The negative impacts included stress and anxiety, a loss of family equilibrium, and concerns about their child's development. Parents also had very similar decisional regrets, including wishing they had taken better care of themselves, feeling they were responsible for their child's preterm birth, and wishing they had been more involved as parents while their child was in the NICU. Parents viewed their child's health as being good, with parents rating their child's health as a median of 9 out of 10 when their child was 18 months old. There were family important outcomes that came from this study that are not being systematically measured. And this includes breathing, feeding, sleeping, medical fragility, and behavior. Parents wanted to be better prepared for their child's NICU trajectory, their role as parents of a preterm child, and what they could expect at discharge. And they also wanted more optimism from their medical team. So a few key messages from the Parents' Voice project. Parents have a generally positive perception of their child, and they see their child's preterm birth as having both positive and negative impacts and report themes of resilience and positive transformation resulting from their child's birth. For parents, their child's functioning is far more important than a medical diagnosis. The NDI classifications that are used in neonatal follow-up don't necessarily correspond to the lived experiences of parents. They're more pessimistic and they sometimes miss the point. And finally, many family important outcomes are not being measured in research, including respiratory health, eating, and sleeping behaviors. So in conclusion, it's essential that measured outcomes and the classification of outcomes in neonatology should be redefined, even if this does take a lot of time. Severe categories should really no longer exist. Rather, outcomes should be described. For example, we could say that a child uses cochlear implants or hearing aids because they are deaf, or that a child has non-ambulant cerebral palsy, rather than just classifying the child as having these children as having severe NDI. Function should be measured and not just diagnoses, and research is developing quickly to integrate stakeholder important outcomes. So before I finish up, here's a picture of Mary now. She's a 15-year-old in grade 10 here in Montreal. At 18 to 24 months during her follow-up visit, I think she probably would have been classified as having a mild to moderate NDI, but again, that would have meant nothing to us as parents, and it really still doesn't today. For example, she had an expressive language delay, which is measured in outcome research, and had a lot of lung problems, which to us was more serious, and this isn't actually measured in outcome research. Today, Meredith is amazing. She has to work really hard in school. She has difficulty in math, but she's organized, she's hardworking, has friends, she's active, and is happy. Thank you so much. And like the other speakers, I look forward to answering any questions you may have. Thank you.
Thank you so much for that, Rebecca. We do have time for a few questions and discussion, so I am going to turn it over to Dr. Thierry Decazes, who is a neonatologist and also co-principal investigator of the CHEER project, to lead us in questions and discussion.
Yeah, thank you. Thank you, everyone. It was an outstanding presentation. So I really like the, emphasizing the importance of the patients and families' input in the design of the study and the protocol, as much as the importance of engaging families in the outcome, questions. What's the best outcome and what are the outcome variables we need to take in considerations for clinical trials. We have time for a couple of questions. Please raise your hand or write it in the Q&A. I have one for you, George. So the deferred consent sounds, logical and legitimate for studies that are clustered, randomized. Patients can opt out, after the intervention has taken place, because this is the intervention that is provided regardless. I think it also makes sense, and we can build a rationale for studies that require immediate interventions in the case room, like the meconium aspiration example. My question for you is the 12 to 24-hour zone where the interventions, is taking place. So the very early or kind of prophylactic approach where it's challenging, right? Because some research board think that there is still, time and we can put in place a process to get consent, so individualized consents, whereas, practically speaking, it's extremely difficult to get consent with such a short notice. And then we are losing families that, we are not provided with this opportunity. So do you have any, advice or thought about this challenge that we will see coming, for years with so many studies happening in this very short period of time?
Yeah, I think you're right. This time period is challenging as well in the first 24 hours, because you might not have much time, because and it's quite emotional for the parents. So, I mean, I think even on the NICU, I think it is possible to do have a deferred consent approach. I think even in that time frame, we have done studies around intubation, for example, where we said, look, we never know if a baby needs an intubation, so we can't ask all the parents. And even if that was a week or 2 weeks down the track, we would have we had deferred consent to do the study. So I think the deferred consent approach on the NICU is possible. It just depends always on the study, isn't it? Like if it's a new drug study or comparing some drugs, it might be more challenging to use that approach. But I think it is always possible also to use that deferred consent approach on the NICU.
Okay, Rebecca and Betsy, do you have any, thought or perspective on this challenge of very early consent or deferred consent for studies that require randomizations very early after birth, or advice, or?
Yeah, I mean, sorry, was it from both me and Betsy?
Yes.
Betsy, did you want to start? You probably have.
No, go ahead.
Okay. So I'm just actually looking, because of the previous talk that I had planned talks a little bit about this. It's kind of more from a parental perspective. So, I mean, I agree with, I think a lot of what Jörg said is really important, because again, if you giving consent into the delivery room, you often have people with moms with less optimal prenatal care, or quick deliveries are excluded. There's all those problems with that. I think it's really important that parents understand what the research is about, first of all. So again, that's a really tough thing to do, because it's a situation where it's very fraught and parents are really, really stressed out. For example, they're in shock. So I think also there's like one of the criticisms is the loss of autonomy for parents in deferred consent. I think research suggests that most parents actually support it, if I'm not misunderstanding, if you go back and actually look. But one area of concern is their perceived loss of autonomy. But you have to remember too that in a case of an emergency situation, parents don't really have that much autonomy anyway. So it's not so it's not like you're necessarily taking an autonomy that they already had. In the case of premature birth, for example, pretty much everything is out of their control. It could be interesting, a future area of research to look at consent as one thing that parents think that they actually have control over. So I won't go on too much, but I think parents should be asked about this as soon as the children are stable. You don't want to wait too long to speak to parents. You need to catch them. And generally babies, at least in the NICU, are stable kind of at the beginning sometimes, and things go downhill later. So I think it's really important to establish trust with parents as well. That's really, really important. And that can be done in lots of different ways. One last thing before I turn it over to Betsy, if she wants to reply. I think parents really want to know that there's going to be minimal risk or minimal additional risk to their children as well. It's really important, or that their patient rights won't be affected. I think that's an important thing, that if parents decide they don't want to participate, that they know that their children are still going to get the best medical care that's possible. And also to convey to parents that this has been approved by an ethics board. This isn't something you're just doing, and that the potential for better research, hopefully, or for better future for their child outweighs the risks of whatever the intervention is, ideally. So again, that's all stuff that I think should be communicated to parents. It's a lot, sorry, but yeah.
No, that's good. That's excellent. Thank you. Betsy, have anything to add?
I think, Rebecca really, there we go. Rebecca covered the majority. I think the one thing I just want to mention is working with George. We did a little bit of pre-work for the Survive trial that we're collaborating on, and to get perspectives. And very interestingly, and not surprisingly, some of the people who, it's very anecdotal, of course, but, I talk about the baggage that people walk into the room with, right? And so, we all walk into that room as parents with whatever our life has been. So whether you're in a historically marginalized population, or you have had significant developmental trauma and your trust is, not there, the people that express that have had a really darker time in their lives, and expressed that they were not a fan of deferred consent and had concerns about it. Everyone else was very understanding. So I think just like looking at, and to me, again, we go back to like, what is the messaging that you can tailor for those families, right? It's all about like figuring out what works for different populations, and how we can get things that resonate clearly in a really tough time.
One last thing as well, I'm going to pop in. I think it's really important, and maybe studies do this more now, maybe it really depends on the researcher, but I think it's important that parents have the option, and I think Betsy, you touched on this, of knowing the outcomes of the research that they're participating in. So just as an example, like 15 years ago, I was part, just after Marin was born, of a study looking at whether a lactation consultant, if I remember correctly, the presence of a lactation consultant changed the amount of breast milk or the composition of the breast milk that was produced by mothers. And it was really interesting, but I don't think I ever received any information about what the actual, I have no idea what the findings for that or the outcomes of that study were. So I think it's important that parents, can check a box or something saying if they want to be informed about the findings from the study that they're participating in. I think that's really, really important as well.
Yeah, we hear that more and more now that we engage patients in designing the protocol and the grant. The return of the results is absolutely key. Well, thank you. Thank you for the three of you. Megan, I hand over to you for last words.